Well, I think I was set up a little bit here, Mehdi, because just a second ago, both you and Ramon said that once you learn the tibial technique, you don't need any CTO devices, and I get to talk on CTO devices. So thank you very much to the organizers of this meeting for a talk that you don't need to listen to. So with that, let me start with what we have options for. They really do fall into the categories that you see here. Obviously, we've seen subintimal wire and reentry, and a beautiful example, Dr. Ida using what we call the knuckle wire technique. But there are devices that fit into the true lumen devices and then the CTO devices for reentry. And you should really understand how each of these works slightly differently, but at the end of the day, I think for both SFA and CTO, getting used to at least one of the list that's in the true lumen section and one of the list that's in the reentry device section will really go a long way with you understanding how to do these procedures. And I'll give you a few examples of novel techniques for using these CTO devices. Since they become irrelevant, we'll actually show you some interesting ways to bring them back into relevance. So this is the obvious subintimal recanalization of an SFA CTO. The wire starts straight, you make a knuckle, the wire basically tries to stay about the same size as the vessel, and then you want to re-enter with it with a straight wire. So this has been demonstrated over time, and all the operators know how to do this. But what are the advantages and limitations of the devices that we have when the wire doesn't work? There are devices with differential dissection, like the Frontrunner device, which allows you to sort of move the catheter through the occlusion by opening and closing the jaws. The crosser catheter, which you're familiar with, is a vibrational technique. You've probably seen the Wildcat, which is kind of an Archimedes rotational device that's attached to a juice box, which is the energy behind it. The Viance catheter, I think we heard some examples of, and the TruePath. These are some of what are available. And it's interesting that you mentioned that they aren't used very much anymore, because if you look at the device development in the CTO space, the devices haven't changed that much since 2014. So 4 years without much. On the reentry side, they have gotten a little bit smaller. We started with the two that you see on the right, which is the Outback and the Pioneer being an IVUS-based reentry device. But some of the more smaller devices, like the N-tier Stingray and off-road devices, these are now being used for even tibial reentry when you can't use a strong wire to get through. So the Frontrunner technique you should be aware of, you want to use a microcatheter very close to the end of the catheter so you don't get buckling and get into the subintimal space. Just one little tip for the tibial Frontrunner technique. The CTO crossing by using a crosser device is essentially using vibrational energy at the end of the catheter and just using the power of the catheter to vibrate through an occlusion. It can be very useful in the tibial space. The TruePath device, it obviously has a rotational burr at the end of it. It's a diamond-coated burr, and you can be really pretty prolific with getting it through small segments, but be aware that in the larger vessels, this is probably something that you want to steer away from because it might go into a small channel. The Viance catheter was showed earlier. This is just an example of the rotation of that device inside a total occlusion, which allows crossing and then ultimately recanalization. So let me actually show you a couple of techniques where CTO devices may be of some utility, Ramon. So here's an AT CTO, terrible distal runoff. We've already seen very skilled operators getting into tibial vessels which don't seem to be existent and being able to recanalize them. So this is a good example of a terrible target for a tibial recanalization, but this is what we had. So distally, the only thing available were these kind of ugly looking areas of the AT, of the occlusion, and antegrade access really didn't get us through. So what was done was a wire was taken from above. There was some progression of the wire and a balloon into the proximal segment. We couldn't reach the distal end. So like Mandy was saying earlier, he says, would you ever balloon proximally before you get distally? In this case, we actually did balloon to be able to see distally. And then, because it was such a lousy reentry site distally, we were able to recanalize by going retrograde through this kind of ugly looking AT. Ultimately, a balloon was placed from above and the outback, or from below, I'm sorry, and the outback catheter was brought from above. And in order to get the two lumens to connect, the balloon was punctured. So this was a below-the-knee reentry to use the outback into a segment. And then ultimately, after that was punctured, and there's not a big thumbtack that comes along with this, by the way. You have to buy that separately. And then the balloon was pulled from the foot access site, which ultimately then allowed recanalization by ballooning from above. So these CTO reentry devices are useful when you run into big problems with heavy calcification. Another example of using these devices when you really can't get in from above, this is another AT CTO with a diffuse area perineal. The perineal was fixed first, and kind of like in the case that Peter showed, that it wasn't enough, in my case, for just the perineal to be recanalized, so I had to bring the patient back to fix the AT, and the only access site was at that dorsalis pedis segment. Patient was on their back and did ultrasound access into this dorsalis pedis, retrograde recanalization, and ultimately this wasn't enough, so we had to do a double balloon technique where there was a balloon from above and a balloon from below, and with the balloon from above and the balloon from below both dilated, both 2.5 millimeter balloons, ultimately a channel was created between the two segments, which then allowed the ability for the wire to pass and good antegrade flow and out to the pedal arch. So in conclusion, currently available CTO devices increase the costing success from 67 to probably about 90%. These are statistically what the numbers for these devices have shown. Each of these devices have very specific characteristics, whether they do better for fibrotic lesions or calcified lesions, et cetera. My advice, though, is essentially get yourself familiar with 1 true lumen or 2 true lumen devices and get really facile with a reentry device, because ultimately, even with situations where it looks like you can go retrograde, there are times when you need the 2 wires to be able to connect. Thank you very much for your attention.